we move on to the next talk, and that is by Dr. Anand Parthasarthy, and he'll be discussing about customized PRK in keratoconus, when and when not. And that's a good question, when and when not, because whether we should do it or not, that is one, and which are the cases who will improve, and what is the cutoff of thickness, what is the cutoff of other parameters wherein we can do it. Dr. Anand Parthasarthy.
Thank you for allowing me to be a part of this IC, Rajesh. I think for scleral lenses, Dr. Jain, what I find is that it's becoming more and more of my practice. I don't know whether it's the graying of the hair which is making me less adventurous.
Have really worked well in large cones as well as even after DALCs, wherein the landing zone is at the limbus, and some of the designs they have landing zones even beyond limbus. And these patients, they are very comfortable with these lenses. And we have seen cases wherein in one eye we have fitted corneal lens, and in the other eye we have fitted scleral, mini-scleral lens, and the patient keeps telling that the other eye, I don't feel anything is there, but in this eye I do feel little bit. So the corneal lenses, the patient is not as comfortable. And the current generation lenses have become very good. They provide very good visual rehabilitation and comfort as well. क्या हुआ? अरे पहले से check करना चाहिए. क्या करते हो यार? बैठे रहते हो. Time होता है ना. Yeah, please.
What is your opinion regarding bilateral CCR in adults and in children? Whether you do bilateral CCR at the same time?
See, bilateral C3R, I would avoid doing it. In large majority of cases, it is keratoconus is asymmetric. As a rule, it is asymmetric. In case there's some issue, can Amit, can you just connect yours? Meanwhile, he will check. So in a large majority of cases, because keratoconus is asymmetric, so you may have to, you may just like to do cross-linking in one eye. And there are some reports, I mean, we do get referrals from everywhere of post-CXL keratitis. So to some extent, I would say we are a little scared that way, that there is a risk of post-CXL keratitis as well. So there's no harm in waiting for some time, do cross-linking in one eye, see how it behaves, and manage it well, and then maybe later on we can do it in the other eye. Yeah. Yeah. So that's why bilateral, we don't do it, because safety is again an important issue. I mean, management and arresting progression is one, but safety of the cornea is also an issue.
Where the cross-linking does for 1 hour, the eye is open, basically, with everything off. So your OT environment should be cultured regularly. You should make sure the ventilation is proper and so on.
Okay.
Boss, are we good to go? Yeah. Thank you so much. And I'll try and see if we can keep it to the time. So I've been asked to speak on TopoLink, PRK, and collagen cross-linking. And ectasia treatments are broad. You got topo-guided PRK, you got accelerated and conventional, you got specialty contact lenses. Phakic IOLs also fit into some of these paradigms. And what are the bugbears for patients with keratoconus? It's poor, uncorrected, or best corrected vision. You tend to have halos and ghosting. You have a patient's fear of losing vision. I'll start with one patient, a 43-year-old male government employee, underwent cataract surgery a while back and was referred to us for some cornea problem because the cataract surgeon felt that the surgery is perfect, patient is not improving, and the best corrected was 618. And when we actually looked closer, we found that patient had actually undergone a LASIK. So about maybe 10 years back, for a -10 in both eyes. So it's, remember the Hamilton, people who don't know the history are doomed to repeat mistakes. And we put them on a scan. This was the right, and this is the left eye. You can clearly make out it's actually a post-LASIK ectasia, which was the primary reason for drop in vision, not the cataract. And the suggested treatment was basically to do collagen cross-linking intacts. We went ahead with collagen cross-linking because that was the conventional wisdom. And follow-up, patient was stable, then lost follow-up, and came back in 2013 with something like this, with a slightly irregular cornea, definitely, but almost about 8 diopters across the pupil, which is a challenge. Now you got to try and correct this. And we then decided to offer the TopoLink PRK. And plan was maybe right eye we do the glasses and the contact lens, and the left eye we do a customized cataract surgery. And patient presented, this is the right eye, and there is some planning involved wherein you try and not correct all the spherical part, or you correct about 50% of the cylinder. And if you're interested, I could discuss it one-on-one with you. But there are some steps on the platform. This was the wavelight, which allows you to modify the protocol on how much you want to ablate the sphere and the cylinder. Aim is to basically maintain the sphericity. And if you look at the ablation protocol, this is the patient's cornea, which is on the right lower side, and this is the ablation pattern. So it does try and focus the ablation on top of the cone, and it does an additional peripheral ablation to take care of the myopic treatment. That is, you're flattening the cornea, so you need to actually steepen the periphery. And this was the other eye. And broadly, you can convert a cornea which is like this into something which is more regular. So this patient can now be given a good glass with a good refraction. You can actually get them about 6'9", 6'12". So this is pre and this is post. For the other eye, something similar. This is a more eccentric cone. So you are limited by tissue, but you can make it reasonably regular and then think about doing something with respect to your cataract surgery. So this is the left eye, 36 months follow-up, still reasonably stable. And we put this patient on the eye trace, and you can find that there is an improvement in the suggested clarity of vision. Patient also feels that the glare and the halos has come down. So when you look at interventions for irregular corneas, or for that matter keratoconus, broadly how I feel to define it is in front of the cornea, on the cornea, in and beyond. So on the cornea, specialty contact lenses. In the cornea, you're looking at CXL, PRK. On the cornea, CXL, PRK. In the cornea, you got rings, you got SMILE, CXL, and beyond, you're looking at phakic IOLs and IOLs as well. Now, CXL and PRK is a combination treatment where the combined ablation probably needs about 50 micron. The aim is, of course, not to give complete optical correction. And that is the bottom line when you're looking at these patients. You're still going to give them a pair of glasses or a specialty contact lens post this. What is the principle behind this? Principle is you got to image the tomography, topography, and the wavefront aberrometry. The TRK ablates and flattens the imperfections of the keratoconic corneas and tends to treat the high-order aberrations. It improves the central corneal asymmetry, especially prior to collagen cross-linking. So I prefer to do this ablation before I put them on CXL. And it's not a new concept. It's been described in 2006 for form fruste keratoconus. So the concept is not actually very new. There are, of course, multiple protocols. This is the Athens, where they do a bit of sphere and cylinder, limiting it to 50 to 70 microns, suitable for early keratoconus. And there have been some good, reasonable results, and you can make out most of them about -3 kind of spherical cylinders. So you're not looking at very advanced beyond 5, 6, very unlikely. The epithelial thickness is important because we do know that in keratoconic corneas, the epithelium over the apex is always going to be lesser. So when you're looking at ablation, you may probably look at 50 microns as a starting point, and there are multiple machines, and I'll touch upon it as well. But now with most OCTs, you can actually get epithelial thickness. It's a good measure to before you start and punch in how much PTK or trans PRK you're going to do. In the PTK, the intended ablation is about 50 microns. It's basically, if you can get a measurement, it is good, or a random 50 is reasonably good. And you do a bit of ablation on top of the cone. So the conventional modality is that why would you touch ectatic cornea with laser? Because that will increase the ectasia. But here it's probably a very non-intuitive way of working, wherein you flatten the cornea and then do collagen cross-linking. So you're not fixing the cornea in an eccentric place. So that is the concept. We do have patients whom we have done collagen cross-linking done earlier, came back to us still not happy with vision. Maybe 3-4 years later, we've actually done a TopoLink PRK. Of course, there are some modifications on the nomogram, which we could discuss if you're really interested. So this was the first published report on using trans-epithelial PTK followed in patients with keratoconus. And you can actually regularize. So if you see this topography in the published case report, you get a flattening of the steeper part. The upper part is still ablated, but not that much. Now with newer nomograms, it is actually possible to do that as well. So broadly, people have combined it with intracorneal rings. We do have follow-ups of about 10 years of intracorneal rings combined with PRK. But the challenge is that the clarity of vision will never match a contact lens. You're still going to end up with a contact lens later. But it does help to stabilize, and the uncorrected vision improves. So these are patients who had, as I said, about 2.5 diopters. In about a year, you're stabilizing them to about a diopter plus. So they are within the range where they can comfortably manage with a glass, or if you still want to give them contact lenses. And stability is good. Over 1 year, most of them do have stability or have an increase in the vision. Now, I call it the NN Bangalore protocol because I told Rohit, I said, everybody has it after their city. Why can't you put it after your city? So basically, the concept is to look for the location of the cone. Central and eccentric is different. So you have Q hyperprolate, so you do a topolink correction with and without the refractive part. And the eccentric part, you're also doing an aspheric ablation. And if you have reasonable central data, a central pachymetry, then you touch the refractive part. And what is the cutoff? Most patients, less than 450, you're probably not being able to offer this. Then you're looking at either a plain CXL, or you would need to offer a ring, which is a peripheral implantation, so you have more thickness there. 45 to 55, which is probably a grade 1 to 3 in most classifications. You can combine with Intacs if you have a good thickness centrally. So post Intacs, if the patient actually moves the cone and you have some irregular part in the central part, you would of course be more conservative. You're not going to touch 3-4 diopters, probably a couple of diopters is what the max you can do. Now present indications is combination. There is a concept called TREC, which was released on the Swin machine. I have access to it, I'm slightly lucky, wherein the TPK, that is the PTK is the same, and they ablate about 20 extra microns on top of the cone, which is slightly different from the wavelight platform, where they also do a hyperopic ablation. So it is only about 20 microns, that's the limit. They tend to flatten it. We have about 1 year follow-ups. Between the two, if you ask me, I prefer the wavelight because I find that it's a lot more controlled in terms of the outcomes. You do get better refractive correction. You can, of course, use it post-keratoplasty and post-Intacs. There is eligibility criteria, which I mentioned, but an important fact is there has to be no active allergic disease, no active ocular inflammation, and definitely no central scarring of the cornea, because these would compromise not only the healing but also your results. So where does it all fit in? Basically, if I look at early management of keratoconus, you decide early and advanced, it is probably at the early part where you have a bit of progression, you got reasonably regular astigmatism, and you are thinking you want to give contact lenses. You can do CXL, you can follow it up with the toric ICL if the spherical ligament is significant, or you do a TPRK with the collagen cross-linking, give them a pair of glasses or contact lenses. In the irregular part also, you can combine Intacs and TPRK. Intacs would be my preference in terms of rings as the primary offer to regularize it, bring the cone to the center, and then if you want, either give contact lenses or do a ablation. In conclusion, the topography guided ablation improves both the uncorrected, best corrected, the quality of vision, and of course the contact lens fit. Meticulous and methodical planning is essential to ensure optimal results, and it can be used with post grafts as well as post intracorneal rings. Thank you so much for your presence.
Thank you, Dr. Anand, for